So if we go back to this model of conventional care, where if this is anti-disease care fighting Frank's cancer, and over here is comfort care and comfort care near the end of life, think about this transition and how challenging that is. For some people, that word palliative is only a synonym for hospice care. That is wrong. And if there's another take-home I want you to take from this talk, it's that palliative care is not just a euphemism or a synonym for hospice care. If you think that way, you really aren't going to get the benefits apart or across the whole spectrum of illness. If I were to ask you, if you have cancer, if you have mesothelioma, if you have lung cancer, do you want to live as long as possible? You would all say yes, of course. You want the best possible treatment to live as long as possible. And if I asked you, do you want to be as comfortable as possible? Comfortable in your physical self, your emotional self, in the social setting of your family, and in your sense of spirituality, you would also say yes as well. And if I asked you if you wanted to choose, you would likely say, well, I would rather not choose. I would rather have both together, which is what is shown in this diagram. When Frank came into the emergency department, Frank was suffering from his cancer. He had pain. More than his pain, he was worried. He wanted standard approaches to make his cancer better. But as importantly, he wanted to feel better. And however long Frank lives, if it's months, years, decades, across that course, we want to assure that the best approaches to relieving his suffering and supporting his quality of life are applied throughout that care. If Frank dies of his cancer, we want to be sure that he gets the best hospice care. In this model, hospice care is the completion of good cancer care. But the most important thing for you to remember here is that palliative care can extend for months or years, and it doesn't mean that you have to stop taking care of the cancer. In fact, there's a good reason to think that if you make people comfortable, the therapy works better and they do better with their cancer therapy. So here's a photograph of Frank later. Does this photograph look like Frank needs palliative care? The pneumonia is under control, the cancer is getting treatment, he's waiting at his oncology appointment, he's sitting again with his son, as so many people come to appointments with their family members. I hope you say yes. Well, of course he does. It's not as extreme as when he came into the emergency department, but Frank still needs attention to his physical, emotional, social, and spiritual dimensions of his illness, even though it looks like things are relatively well controlled. So, I hope I've given you a sense that palliative care is interdisciplinary care focused on relieving suffering and improving quality of life. I want you to notice what is not in this definition. It doesn't say how long Frank has left to live, or what will be done to improve Frank's quality of life and relieve his suffering. Simply, the palliative care results in these kinds of outcomes. Therefore, it should be clear that it can be combined with therapies aimed at reducing or curing the illness, or it can be the total focus of care as it is when someone is enrolled in hospice care. So although palliative care grew out of and includes hospice care, it is not the same as just hospice care. It is not something you just save up to the very end. Well, what do you notice about this photograph? I hope you notice that Frank is doing what Frank wants to do. I think for many of us working in healthcare, we have the idea that the whole point is so people can keep coming back to their appointments and keep up with their treatments. And yet the real focus of anti-cancer care is to have the cancer under control, to do the kind of living you want to do. So you notice Frank is playing the drums. He is in rural Vermont. There is no doctor, no organized health care for 100 miles around him. Now, who do you think that made nervous when Frank said he wanted to do that? Frank wanted to do it. His family wanted to do it. It was me, his doctor, that was anxious about it. Part of the commitment to including palliative care as part of the course of care is the commitment to have the patient be the guide. It's about making sure that treatments and goals are patient-centered. And although I was worried that something might happen, Frank and his family appreciated the advice, but still wanted to do what was important to him. And that meant that his symptoms had to be under control, that arrangements had to be made. I hope you get the sense of pleasure. This is the point of healthcare, is to be able to go on living the way you want to live. So if that's palliative care, let's move to the evolution, because I think it illustrates in many ways what you are now some of you expecting and may find in the cancer centers where you're seeking your care. So it started with this woman, Cicely Saunders. She was a nurse, she hurt her back, she had to stop, so she became a social worker, and she was working with cancer patients and saw their unrelieved suffering, particularly cancer pain. And she said, I must do something better. And the surgeon she was working with said, Cicely, if you want to change healthcare, you'd better become a doctor, because they will not listen to you as a nurse and a social worker. So she became a doctor. Do you think she actually changed anything? No. Sadly, doctors do not have the power to just change things. So she built St. Christopher's Hospice, not because it was the only hospice, but because it was a new kind of hospice where Cicely Saunders could try out her ideas about taking care of whole patients. But this is St. Thomas's Hospital in London, one of the oldest hospitals in the Western world. It was founded in the year 1106. Now, as you look at this photograph, you'll notice they have done some renovations since then. And this is a photograph of the palliative care team. So how did we get from Cicely Saunders Hospice to a standard academic center doing cutting-edge approaches to the treatment of cancer? And yet this group, I said palliative care is interdisciplinary care focused on relieving suffering and improving quality of life. Well, can you see who the attending physician is? He has that confident demeanor, and you can tell we're in London because he's drinking tea. Can you tell the nurse here working on the program, and the physician fellow, and the chaplain, and the social worker? This is a conference room off the standard oncology unit. They see patients throughout the hospital, and particularly on the oncology units, working hand in hand with the medical oncologists, radiation oncologists, surgical oncologists, to be sure that the relief of suffering is joined as part of comprehensive cancer care. So in England, they started with dedicated inpatient units, but quickly went to home care teams, and then consultation services that are both in the hospital and in the ambulatory clinic setting, which led to formal training and recognition of the specialty of palliative medicine, which led to health system standards. You'll be pleased to know that in the United States and elsewhere in the world, traveling the same path but going from a different way. Starting with home care teams, but then dedicated inpatient units, consultation services both in the hospital and in the ambulatory setting. There is now formal recognition and training of specialists in this field, and health system standards. This kind of convergent evolution tells that this is a new direction in healthcare, a new emphasis on relieving suffering and improving quality of life. So this is also where I work, UCSD's Cancer Center. There are palliative care programs developing in cancer centers throughout the country. Does palliative care belong in a cancer center? I would say absolutely. So let's go to a different case. This is also a 58-year-old person. This is now Kit. She's a healthcare executive. She's well. She went for a physical examination because she was changing jobs, and a chest x-ray was done, and a lung mass was noted. She had an operation. It was adenocarcinoma. For many of you watching this is something that's happened to you or someone you love. An unexpected event. Now what? Well, for Kit, this could have been two things. One, it could have been very early stage lung cancer, and that's of course what she hoped it would be. It would mean it was stage 1. That means that 2 to 4 people out of 10 with a similar cancer are cured with the surgery alone. The rest will go on to die of their disease, generally in a couple of years. But it could also be cancer of unknown primary, and in that case, it would be inevitable that she would eventually die of the disease. About 5% of patients with cancer, about 1 in 20, do much better than expected and live much longer than is ever expected.